So I'm just going to speak briefly for 10 minutes to set the scene and try and emphasize why we need to integrate both health improvement and health protection. And I'm going to start by just referring to public health. Everybody joining today knows what that is, but I'll show a slide that I commonly use with medical students to try and show how these things are interlinked. I'll then give you some concrete examples why health improvement is so important, both in relation to people coming into contact with the virus, developing COVID-19 and disease severity, then comment on its importance for recovery, which I think is what today is mostly about, and then the need for comprehensive evidence-based interventions at different levels. So just as a reminder, these are the key elements of public health and they interlink. So health improvement, by which we mean addressing preventable risk factors for disease and also their underlying causes. Health protection, which of course we're now focused on, particularly addressing communicable diseases primarily, although it has other aspects. And then also just the interlinkage with services. So looking at healthcare and wider service improvement for population health. And the two are interlinked because at the moment we're focusing very much on health protection. That's been much of the discussion around Public Health England and its future role in terms of those, emphasising those elements. But as everybody knows, non-communicable diseases contribute to far more preventable morbidity and mortality globally. They kill around 15 million people before the age of 70, and that's going to far exceed even the worst projections for COVID-19. And as all of you know, one of the reasons why we, in contrast to some other countries, have been so badly affected by COVID-19 is the burden of NCDs on our population, coupled with long-standing inequalities and decades of underinvestment in public health, as well as specific critiques of our public health response during the pandemic. So to address both the current crisis, which we're still very much in the middle of, and prepare us for future ones, we need better and more sustained attention and investment in public health generally, but health improvement, in my view, in particular. So in relation to why we need to make the case for health improvement to address COVID-19, around 1 in 4 of the population globally has an underlying condition, and I'm going to show you examples from the UK that increase vulnerability to the disease. And also in relation to our most disadvantaged communities in the UK, it's now absolutely clear that it's not a pandemic, it's a syndemic, as the Lancet has said, a co-occurring synergistic pandemic that is interacting with and increasing social and economic inequalities. And this includes in particular the preventable burden of non-communicable diseases, as we'll hear from the other speakers, caused by tobacco use, alcohol, and overweight and obesity. And all three of these risk factors cause increased disease severity in terms of underlying conditions from COVID-19, and overweight and obesity on its own is a risk factor, both for infection and for disease severity. So the measures which we've taken, quite understandably, to address the current crisis have diverted investment and services away from health improvement to health protection. And it's perhaps understandable in the very early chaotic stages of dealing with the pandemic, but overall it's misguided and it neglects the interaction between the two. And just to show you in relation to underlying risk factors, this is the Usher consortium. If you're not familiar with it, I do commend them to you. It's the largest global group. They've repurposed to look at COVID. They have, in this data from the beginning of September, just under 100,000 individuals hospitalized from 562 sites in 42 countries. And you can just see in relation to the underlying risk factors, those admitted to hospital with COVID-19, it's very clear that many of these conditions are tobacco or related, or indeed overweight and obesity as an independent risk factor, and some, including alcohol, also linked to some of these underlying conditions. So that just, I think, brings it home to us. In terms of the mortality challenge, this is a paper from my colleague Jerry McCartney and colleagues. The references at the bottom, just looking at some of the modelling done to deal with pandemic. So we know about the mitigated versus non-mitigated pandemic, the early models from Imperial and others. In terms of reducing life expectancy by about a third in a single year for the population as a whole. And if we'd done nothing, it would have been far greater than that in terms of its impact. But that pales into insignificance with the health consequences of inequality. On life expectancy, those are 6 times greater than even a completely unmitigated pandemic based on the worst case scenario. So COVID-19, which we're experiencing now, is a mortality shock, but it's nowhere near as big as the inequality long emergency. And health improvement in terms of its underlying response, is about trying to address health inequalities and the health of populations who need support the most. And this finally, just a couple more slides. I don't have time to go into this in detail, but again, another paper I commend to you from my colleagues at Edinburgh, just trying to look at all the unintended consequences of the public health measures that we've taken, not just what happens with COVID itself in terms of direct health impacts, but also the things people have been asked to do in the way their lives are restricted, the mental health impacts, the unemployment consequences, the risk, which we've seen certainly with alcohol, with hazardous and harmful drinkers increasing their consumption during the early months and ongoing in the pandemic, and then some of the other behavioural impacts of the public health measures. So this indirectly attributable morbidity and mortality due to the crisis needs a health improvement response. And I think we're not thinking at the moment enough about that. So what do we need to do? Focus on all of public health, not just health protection, reinvest in key health improvement services and policies, some of which actually could add money to the public purse in terms of fiscal measures, address inequalities and recognise these linkages, focus not just on the national, but importantly on the regional and local infrastructure and responses, and build back better with public health and responsive community services and interventions at the very core of our response to COVID-19. So thank you very much for listening. Just a brief introductory presentation from me. I hope that was useful, and I will stop screen sharing now. Thank you.